Okie dokie. So I went alphabetically when I was recording. So now I am on P for peripheral nerves. Started with C on cranial nerves, and then I talked about a bunch of stuff in between. Let me share my screen so that you can get an idea about what it is that I am talking about here. Okay, so let's look at some peripheral nerve problems. We looked at some spinal cord problems when we were looking at low back pain. We looked at cranial nerve problems with the trigeminal neuralgia and the Bell's palsy, and then now we're looking at peripheral nerve problems. So one of the more serious peripheral nerve problems out there is Guillain-Barré syndrome. Guillain-Barré syndrome is an inflammation in many neurons related to infection. So that's what inflammatory polyneuritis related to infection, RT reflection, infection. So it's inflammation in many neurons related to an infection. It's acute, it moves fast, and it's potentially fatal. What happens is there is demyelinization and inflammation of the affected nerves. And so the impulses to the periphery are interrupted. So these people don't have any muscular control of the periphery at all. It happens usually 1 to 3 weeks after a respiratory or a GI infection. And it's basically a really severe immunological reaction. A lot of people get this after the flu, just so that you're aware. And signs and symptoms will start on the outside of the body. So they'll start on the distal end and then they'll move proximal. So they start on the far ends, toes, the fingers, then they move towards the core, proximal. They have improvements. So then when improvements happen, they happen the exact opposite. So because the problems happen from the outside in, then the resolution happens from the inside out. These people will have pain. They'll have paresthesia, the numbness and tingling, and they won't have a lot of muscle tone. They'll have hypotonia. Guillain-Barré syndrome starts with weakness in the lower extremities. So weakness in the legs, and then they'll start having numbness and tingling, paresthesia, hypotonia, areflexia. They will develop orthostatic hypotension and in general hypertension. So when they stand up, they'll have a severe drop in their blood pressure. Excuse me. So when they change positions in the world, from laying to standing or laying to sitting to standing, and they have severe drops in their blood pressure, that's orthostatic hypotension. In general, if they're just at rest, they will have hypertension. They will also have abnormal vagal nerve responses. So this is where, as that disease is moving from the distal to the proximal, once it hits the vagus nerve, we've got some big problems, because the vagus nerve impacts the heart rate, and it impacts the electrical conductivity of the heart as well. So you will have a low heart rate, bradycardia, your beats per minute will be less than 60, and you can develop heart block, which means the electrical impulses that happen between the SA node and the AV node back to ANP land, there's a block in between those, and like the SA node and the AV node will start operating independently, and it can lead to complete electrical shutdown of the heart and asystole. Eek. You will also have people with this problem have bowel and bladder problems. They'll have cranial nerve manifestations, but because it works from the periphery into the core, because it works distal to proximal, cognition is not effective. So like these people will have no use of their arms and legs, and they will be having all sorts of these pins, needles, and pain. and they realize every single moment of every single day. Their cognition is not affected whatsoever. They may not be able to speak, but everything is still intact up here. Sounds a lot like multiple sclerosis, but it works differently than multiple sclerosis. Sounds a lot like ALS, works differently than ALS. But in those two other situations as well, cognitively, totally with it upstairs. So the diagnosis is based on history, on neurological exams, and then we'll do electromyograms for these people as well. Treatments include IVIG, IV immunoglobulins, as well as plasma exchange. So because it's moving from the outside to the inside, the nerves that control breathing are also affected, and they can create respiratory failure. So this person needs constant monitoring. And then what our nursing care surrounding, the main goal of our nursing care is to support those body systems to get the recovery so that these people can have meaningful recovery. Because they're at risk of losing their respiratory drive, this may mean that they're on a ventilator. So, so you have an awareness in nursing diagnosis for the patient with Guillain-Barré syndromes may include impaired spontaneous ventilation related to progression of disease process resulting in respiratory muscle paralysis. Risk for aspiration, they have poor swallow. Acute pain related to paresthesias, muscle aches and cramps, and hyperesthesias. Paresthesias is numbness and tingling. Hyperesthesias is like burning sensation in the fingertips because like the nerves are just hyper rather than hypo, which is what paresthesias are. Impaired verbal communication related to either intubation or paralysis of the speech muscles. Fear, I would be scared if I had Guillain-Barré syndrome, because there's a lot of like, oh my gosh, how far is this going to get to before I have a reversal? You can start recovery. And then a self-care deficit is because they can't use their muscles to accomplish activities of daily living. So let's take a look at myasthenia gravis, which I had content on in week 5, and Guillain-Barré syndrome. So both of them are autoimmune problems. The white blood cells normally produce antibodies to fight infection. In both of these problems, the antibodies attack the body instead. Myasthenia gravis, the antibodies attack the junction between where the nerve and the muscle connect. That causes weakness that gets worse the more you try and move. It commonly affects the eye muscles, speech and swallowing muscles, and the muscles in the arms and legs. It's a lifelong condition, but it can also be very effectively suppressed, so it doesn't really create a whole lot of problems. Myasthenia gravis, all your life. Guillain-Barré syndrome starts with an infection, most likely. And the antibodies attacking the covering of the myelin sheath cause an ascending weakness. So it's not just in the junction between the nerve and the muscle. It's every nerve is losing its myelin sheath. It progresses over hours, days. It can get severe, and it can even affect the breathing muscles, so the diaphragm and the ribs. It usually takes between a few weeks and a couple of months to recover, and most people are fully recovered and they don't relapse. So just to like give you a really solid summary, Guillain-Barré, which is what I've been talking about in this video, inflammation demyelinizes all of the nerves, disease, slowing down the transmission of impulses through the neurons. Myasthenia gravis from week 5, autoimmune disease attacks acetylcholine receptors and not the myelin. Another problem that people can have that's an autoimmune problem when it comes to the peripheral nerves is chronic inflammatory demyelinating polyneuropathy. Let me say that again. Chronic inflammatory demyelinating polyneuropathy. So it's an autoimmune disorder, and that causes motor and sensory neuropathy. And so what people will have for signs and symptoms are systemic weakness in the arms and legs, impaired sensation, they'll have paresthesia, and they'll have absent or diminished reflexes. It usually develops over about 8 weeks. It's not acute, so it's a slower sort of, it's a week's development, not a days or hours. We treat it with corticosteroids and with IV immunoglobulin therapy, IVIG. And we can also treat it through plasmapheresis, where a person gets some of their plasma pulled off, and then all of their RBCs and white blood cells get reintroduced back into the system. There is no end to this. So 30% will progress over these 8 weeks to being wheelchair bound. And most of our work is based on preventing relapse and continual maintenance therapy to have any sort of relapse or further progression of the problem. Tetanus. We talked about tetany a little bit when we talked about the endocrine system. So tetanus is something we actually get vaccinated against. It's in our Tdap. It's tetanus, diphtheria, but tetanus is in there. It's a severe infection of the nervous system. It affects the spinal and the cranial nerves. Adults should get a tetanus and diphtheria toxoid booster every 10 years. You need a Tdap every 10 years. By the way, you need a Tdap every 10 years. Tdap every 10 years, get your vaccine every 10 years. Sites where this tetanus enters. So IV drug use, injection sites, bites from an animal or from a human, and then cuts from stepping on nails or gardening injuries, getting like a farm accident with some steel or some barbed wire. Burns can have this happen. Frostbite, which is basically just being so cold you have the same burn reaction. If you have an open fracture, which means that you fracture the bone so badly that it comes to the skin, and gunshot wounds. So any sort of like thing that interrupts the integument runs the risk of that person developing tetanus from this infection. So signs and symptoms include stiffness in the jaw. I'm sorry. So stiffness in the jaw and neck, and then signs of infection like fever. You may have rigidity of the neck muscles in the back, in the abdomen, and in the extremities. It can cause seizures. And the treatment for this, if we have a person who develops tetanus, is that we administer tetanus immunoglobulin, and then antispasmodics are also brought in. Opioids help with the pain of the rigidity, because that when you have rigidity, you have like a muscle tetany. You have it's like severe muscle cramp, right? And severe muscle cramps hurt a ton. We also use antibiotics. Botulism is, why not? It's food poisoning, but it's food poisoning because of a neurotoxin. So instead of having GI symptoms like we normally associate with a food poisoning, you will have an intact mental status and no fever, and then you start to go paralyzed. So there'll be descending paralysis. So it starts central and it moves outward. It starts proximal and it goes distal with cranial nerve deficits. So patient teaching for these individuals include rest, maintaining respiratory function, and adequate nutrition. And treatment, there is a specific IV antitoxin called, it's an IV botulinum antitoxin. And so what they'll do is they'll do an intradermal test, they'll do a skin test on it first. And then they'll do it, and then they may repeat it every 24 hours for so long. So here's the reason why this cartoon is here is the cartoon is showing botulism. So whenever you have a can, because it's a problem with the food, right? The botulinum got into the canned food, and the canned food was not appropriately canned, and the high heat was not applied long enough, so this botulism or the botulinum wasn't killed. And so therefore the swollen cans that you see, like the dude here on the left hand side of your screen, he's swollen because when botulinum is growing in canned items, it releases gas, and that creates swelling in so then you'll see like metal bubbling, or like the metal looks pouchy or bubbly, or it doesn't, like if your mom or your grandma or anybody that you know cans goods, there's that little button that's in the middle of the canned good, and it's okay to be shelves, it's okay to eat as long as it's been on the shelf and that little button doesn't go in and out. If that button is sucked in, that means that there's good seal on that particular canned item, and the botulinum most likely is not growing. If that button is like able to be pushed in and out, that means that there is a likelihood for botulinum to be growing in that particular jar or can, and it should be thrown out. So interesting information here in the link, just for your own information as well. And that is all I have to say about peripheral nerve problems. Reach out to me if you have questions, continue watching videos, and I will see you in class.